Hi everyone, in this video I'll give you a brief overview of mastitis and specifically puerperal mastitis, which occurs within the first 6 weeks after childbirth. Some key background information: it is an inflammation of the breast tissue related to breastfeeding or caused by an infection. So if it's related to breastfeeding, it's when the milk accumulates in the duct, which results in inflammation. And if there is an infectious cause, it is typically S.aureus or Streptococcus. It is very common and affects about 1 in 10 breastfeeding women, and there are some risk factors to be aware of, and the key ones are trauma to the breast, a blocked breast duct, or a reduced number of feeds. For example, if the woman is not breastfeeding or not expressing the milk or trying partial bottle feeding. The clinical presentation divides into local and systemic symptoms. Some of the key local features are the fact that one breast is affected, which is painful, red and tender, and the symptoms occur a week after giving birth. And some of the systemic symptoms include fever, rigors, and muscle pain and lethargy. And here you have an example of what a breast with mastitis looks like. So you can see quite a lot of erythema and swelling of the breast tissue. Some of the key investigations include just general clinical signs, a possible breast ultrasound, and cytology of nipple discharge. Together with history, there is often enough evidence to give a diagnosis without necessarily doing further examinations. However, an ultrasound can be done if the patient is extremely unwell and an abscess is suspected. And as well as the ultrasound, cytology can be done where you culture the nipple discharge and see what pathogen might be growing, and it is most commonly S.aureus. Important to know, however, is that detecting pathogens in breast milk cannot always be done. It can also take a lot of time, but the milk should be cultured if the patient has severe infection and presents with severe systemic symptoms. The management for lactation mastitis includes conservative management, so the woman should continue breastfeeding and expressing milk, and empirical antibiotics can be given if the symptoms do not improve within the first 24 or 48 hours, and those antibiotics usually are flucloxacillin or erythromycin. It is important to reassure the woman mastitis should not interfere with breastfeeding and should not cause harm to the baby. Additionally, breastfeeding could be assessed if there are concerns as to whether it is done correctly, whether that could be any issues, or whether there's anything that could be improved on to reduce the risk of recurrence of lactation mastitis. The management of infectious mastitis requires, again, reassurance, analgesia, antibiotics, and possibly surgery if an abscess has formed. And it is very important that the woman continues expressing milk and breastfeeding, because a sudden stop can actually increase a risk of an abscess, and there shouldn't be any harm done to the baby when a woman is suffering from mastitis. Some of the key complications include cessation of breastfeeding, which can have emotional distress for a woman who is hoping to breastfeed her child. As mentioned earlier, a breast abscess could form, and there could be sepsis in very extreme cases. There are some things that have been just suggested that decrease the risk of developing mastitis, such as breast massage, probiotics, and acupoint massages, but there have not been any conclusive studies done on any of these options. This was a very brief overview of the condition. If you have any questions, please leave them down in the comments and I'll be more than happy to answer. But other than that, thank you so much for watching.